So it has been found that nowadays the chances or the incidences of problems related to drug-induced pulmonary diseases are increasing, and therefore it is very important to see that which drugs can cause it, and accordingly, if already there is any kind of pulmonary problem, then we should not prescribe this drug, or at all if this drug has to be prescribed, then we have to prescribe them with caution. If we call it as a special precaution, we have to take in that conditions, and patient has to advise, patient has to warn about the signs, symptoms. If you know the word, we have seen it as a exacerbation. Exacerbation is used in many conditions. Drug-induced problem is one of the reason behind exacerbations. Exacerbation means there was a existing disease which is having maybe very small symptoms, or even almost unrecognizable symptoms. It appears to be, it is not a disease free, but it may appear as a disease free, and in that person's because of some other trigger in addition to the previous trigger, some additional trigger will cause it to show symptoms which may be very severe one, and we call it as a exacerbation. Exacerbation means there was some existing condition, there was some ground. It may be mild, it may be moderate type of condition, but it is converted into, if it was mild, it was converted to moderate or severe, or it was moderate, it is converted into severe or as a emergency conditions. So this we call as a exacerbation. So it has been found that it has been understood that many drugs are responsible for this kind of exacerbation, and actually this is what we call it as a pharmacovigilance, where we understand, we try to see that what are the impacts of the drugs. We check the adverse effect of the drug. You have got a full branch of it to what we call as a pharmacovigilance. So in this pharmacovigilance, the data is taken, and from this data, then we can have the tables or information available that these drugs are prone to have, or these drugs are known for or responsible for various kind of pulmonary diseases. So let us see one by one how it is there. Now usually how we can do it, we just like previously we have seen in case of COPDs or other pulmonary problems or asthma. What are various measures? The measures are known to us. It can be chest x-rays, it can be CT scan, it can be sonography, it can be the pulmonary function test, that is respirometry or spirometry test, and accordingly we can, on that basis we can check whether there is a exacerbation, whether there is an increase in the pulmonary disease, or new symptoms are arising, and this we can check after various drugs when on the basis of complaint of the patients. What can be the reasons behind that? This can be because of the hypersensitivity reaction. This hypersensitivity, we have seen it as in a general pharmacology, that it is one of the adverse effects, and these are, we call them as allergic type of reaction. These are allergic reactions. There are various classes of it, and A, B, C, D, E. In that major thing, we have seen that these adverse effects, particularly these hypersensitivity reactions, again they are having various type 1, type 2, type 3, type 4, type 5 type of adverse reactions, and they are because of one or other reasons. If you remember it, these are because of, we have seen it in case of adrenaline. If you remember that histamine is responsible for the severe problem, and in many of the allergic condition it causes severe bronchoconstriction, and for that treatment we call it as adrenaline is used as a physiological antagonist. Physiological antagonist means physiologically adrenaline is having exactly opposite action to that of histamine. So we have seen that these are various actions which are there, which we can see. So these are having respiratory symptoms because of the hypersensitivity. It may be dyspnea, that is difficulty in breathing, cough and fever. It may also cause peripheral eosinophilia, that is increase in the eosinophilic count, and also it can have many other things. Addition to that, we can have chest x-rays, as I told you, sonography or CT scans, and other activities we can do, and we find it. So these are various drugs which are causing the lung. You can have the list of this drug. That is, example of these are the drug from the class of anticonvulsant, antipsychotic, antidepressant class. Example of these are carbamazepine, chlordiazepoxide, fluoxetine, phenothiazine, phenytoin, trazodone, tricyclic. This we shall be studying as such in CNS when we will study. Anti-inflammatory like aspirin, gold, methotrexate, penicillamine. You might have studied this when you have seen autokite, because aspirin is causing inhibition of prostaglandin. Antimetabolites, this year you don't have it, it is in next year, that is in they are used in cancer treatment like azathioprine, cytarabine, fludarabine, gemcitabine, 6-mercaptopurine, methotrexate. These all are there. Antimicrobial also you will encounter in third year, that is like amphotericin B, ethambutol, isoniazid, minocycline, nitropurantide, paraaminosalicylate acid, streptomycin, sulfasalazine, sulfonamide, etc. Then the drugs which are having biological response modifier, that is they are acting like natural biological chemicals. So these are like GM-CSF are there, that is granulocyte macrophage colony stimulating factor, very popularly called as a GM-CSF, interferon, interleukin 2, TNF, that is tumor necrosis factor. The drugs acting on cardiovascular system like amiodarone, angiotensin convert. This year we have studied this. Angiotensin converting enzyme inhibitors, anticoagulants, beta blocker already we have seen, we have discussed it also many times. Dipyridamole, flecainamide, hydralazine, then hydrochlorothiazide, protamine, and tokenide. These are various agents which are there. Various chemotherapeutic and immunosuppressive agents like bleomycin, busulfan, chlorampicol. These are again anti-cancer drugs. Cyclosporine, and some of these are immunosuppressive agent. Etoposide, hormonal agent like bicalutamide, nilutamide, tamoxifen, melphalan, mitomycin C, nitrosoureas, procarbazine, vincalcolides. These are all used either in anti-cancer or in immunosuppressant. Then various contrast media and intravenous substances like blood, ethanolamine oleate, ethiodized oil, talc, some illicit drugs which are not approved but people take it for pleasure purpose. We have seen this drug earlier, some of drug we mentioned. Example of these are cocaine, heroin, methadone, methylphenidate, narcotic and sedative drugs, and many other drugs like appetite suppressants, then beta mimetics like terbutaline, ritodrine, bromkriptine, dantrolene, L-tryptophan, methysergide, mineral oils. So there are many things which are causing, and unfortunately some of otherwise are very safe to other people, but in some cases, as I told you, if it is hypersensitivity reaction, they can cause it very severely in patients. So these are the biggest problem these drugs are having. Apart from hypersensitivity reaction, what are other activity? Some of the drugs can cause pulmonary edema, and because of that it causes acute respiratory distress which occurs for several hours. It is because of the capillary endothelial injury which is causing increased permeability, and therefore there is a edema. Chest röntgogram, that is röntgograms are X-rays, they show diffuse ill-defined acinar infiltrate and normal heart size. So these are the reasons. Then another cause they are causing is interstitial pneumonitis or fibrosis. This is another one where it is inflammation of this pulmonary edema, and these are slowly progressing cough, dyspnea, weight loss and clubbing. We can have again X-ray here, and X-ray can suggest what kind of problem it is there. Then next are the pleural and mediastinal disorders. That is pleura, you know, it is the external covering of the lung, and if there is a problem, then it will not allow lungs to have a proper contraction and dilatation. So these are various conditions. So these are there will be resolving spontaneously or with discontinuation drug, which are drug-induced systemic lupus erythematosus. There are many drugs which are responsible for this systemic lupus erythematosus. which is sort of autoimmune disorders. When drug will combine with some of the proteins, they will cause this SLEs, and this SLE will cause so many action. One of the action is the respiratory system in that. So it can cause pneumothorax, which may complicate systemic chemotherapy and illicit drug use. Hemothorax or mediastinal hematoma can be complications. Then pulmonary vascular diseases, there can be many cytotoxic agents, they are causing it during the treatment of malignancy. This is the occlusion of pulmonary venules, and because of that there is an increase in the arterial pressure, and that causes problem. This can also be caused by various illicit drugs like cocaine, amphetamine, etc. We have seen them. Alpha adrenergic nasal spray also been associated with the interstitial fibrosis and obliteration of a pulmonary vessel. We have already seen alpha adrenergic nasal sprays. If you remember, we have called them as a xylo, metazalin, etc. So these are all drugs which are acting on alpha 1 receptor. Estrogen containing drugs and other appetite suppressant also been associated with the pulmonary hypertension. So these are various drugs which are causing various pulmonary hypertension and other activities. Then drug induced lupus, the drugs may exacerbate underlying lupus erythematosus. Already I told you, exacerbation already we have discussed many times. Exacerbate means there is underlying disease was there, there may be almost no symptoms, but once drugs are there, it will exacerbate which was underlying lupus. The lupus was there, no significant signs, symptoms were there, but now because of drug it is there. So we call it as a drug induced lupus. We have seen just SLE or lupus erythematosus, systemic lupus erythematosus, and these are very typical condition or allergic conditions because of the hyperimmunity of the people. So there are many problems can be found apart from these lung problems. It can be fever, myalgia, rash, arthralgia, arthritis, serocytosis, etc. Lung and pleuras are involved in around 50 to 75% of the cases, and this causes pleural effusion with or without pleuritic pain, that is pain in the pleural area. Diffuse interstitial pneumonitis and alveolar infiltrate are there. So these are various sign symptoms they are causing. Let us see what kind of drugs are having problem, or the drug which can cause asthma or drug which can exacerbate. You can have this list in better way. This is important list. Example, that drugs which can increase asthma or affect asthma more, or which we can exacerbate asthma, as we say. We have seen some of drug. Example of this is aspirin. I think we have discussed why aspirin. We have seen the mechanism of aspirin. Can anybody tell how the aspirin can cause increase in asthma? Anybody remembers? Don't try it. Instead, you can immediately unmute yourself and speak out if you know. We have studied that mechanism earlier while studying pharmacology.
Sir, by causing inflammation to airways.
Why? Why it should cause inflammation to airways? It is anti-inflammatory, Vaibhavi. Aspirin is an anti-inflammatory drug. It causes inhibition of prostaglandin synthesis. Aniruddha, why it causes bronchoconstriction? No one? Okay, you go through this and answer it on our group. Why aspirin should cause? What was the mechanism of aspirin? Okay. Then these are various drugs. Beta blocker, again we know the mechanism. Why beta blockers will make problem in asthma? We have studied it earlier. We have discussed it so many times, at least not less than 3 times we have discussed these both issues. Okay, this is a list which is causing dipyridamole, hydrocortisone, interleukin 2, methylphenidate, nitrofurantine, protamine, sulfasalazine, timolol, zinc alkaloids. These are the drugs. Then other drugs which are causing bronchiolitis obliterans. Pass me, class with them. Pass me. Timolol, bronchiolitis obliterans. These are there. They are causing and it causing pneumonia. Like drug are amiodarone, bleomycin, cocaine, cyclophosphamide, methotrexate, mitomycin, C, penicillamine. Then radiations in cancer, sulfasalazine. Then the drugs which causes systemic lupus erythematosus, we have already seen that it is very difficult condition. It causes sort of autoimmune disorder is triggered because of the drug. It was earlier nascent, it was sleeping, है ना, सुप्त बोलते हैं मराठी में, हिंदी में कि सुप्त था पहले, ज्वालामुखी जैसा कि ज्वालामुखी के चांस थे, भूकंप के चांस थे, सुप्त था, पर जैसे उसको कुछ चांस मिला, then it will come out. So like that, it is a nascent one. It was not having activity, but once drug goes and it triggers it, it will cause systemic lupus erythematosus. This is example of drug are diltiazem, diphenhydramine, hydralazine, hydrochlorothiazide, isoniazide, minocycline, para-aminosalicylic acid, penicillamine, procainamide, propylthiouracil, streptomycin, sulfonamide. Then hypersensitivity reaction and infiltration into that, these are azathioprine plus 6-mercaptopurine, vasalpan, fluoxetine. Then various radiations. The drug which are causing interstitial pneumonia or fibrosis, example of these are amphotericin B, bleomycin, vasalpan, carbamazepine, chlorambucil, cocaine, cyclophosphamide, diphenhydramine, flecainide, heroin, melphalan, methadone, methotrexate, methylphenidate, methysergide, mineral oil, nitrofurantine, nitrosourea, procarbazine, silicone, tokenanide, and zinc alkaloids. Then there are drugs which can cause non-cardiac pulmonary edema. The edema is there which is not because of any cardiac reason. We have seen pulmonary edema because of the heart failure earlier, if you remember, during CCF. So pulmonary edema without any cardiac, this cardiac function is normal, but there is a pulmonary edema. Example of these are beta-mimetics like terbutaline, ritodrine, chlordiazep oxide like cocaine, cytarabine, ethiodizide, gemcitabine, heroin, then hydrochlorothiazide, methadone, mitomycin, phenothiazines, protamine, sulfasalazines, tocolytic agents which break down mucus, they are called as a tocolytic agents, tricyclics, tumor necrosis factors, zinc alkaloids, parenchymal hemorrhage. Some of the drug causes hemorrhage. In that, example of drug are anticoagulants, azathioprine plus 6-mercaptopurine, cocaine, mineral oil, nitrofurantine, radiations. The drug which are responsible for pleural effusion, these are amiodarone, anticoagulants, bleomycin, bromocriptine, vasalpan, GM-CSF, interleukin, methotrexate, methysergide, mitomycin C, nitrofurantine, para-aminosalicylic acid, radiation, and various tocolytic agents. Then this pulmonary infiltrate which are causing the problem. Example of these are there are many of these. Then those which are causing pulmonary infiltrate with eosinophilia, again amiodarone, amphotericin B, bleomycin, carbamazepine, diphenhydramine, ethambutol, etoposide, GM-CSF, isoniazide, methotrexate, minocycline, mitomycin, nitrofurantine, para-aminosalicylic acid, procarbazine, radiation, sulfasalazine, sulfonamide, tetracycline, trazodone, etc., appetite suppressants like other agents, vasalpan, cocaine. These are there are many drugs in appetite suppressants, heroin, methadone, methylphenidate, nitrosoureas, radiation. So these are all the drug and their causes, what kind of problem they can cause. They are, summarized into this, that how they are causing. Drug wise, when we see the detailed pharmacology of drug, then we understand either what can be the mechanism, and when there is no mechanism is mentioned, many times it is a hypersensitivity reaction. Drugs are selectively reaching to that particular area, there they bind with one or other kind of protein, and because of that either they pose this hypersensitivity reactions, or they may cause some of the stronger reactions. So this is how these drugs are acting. There are many examples of drug induced bronchospasm. We have seen aspirin, we have seen beta blockers, there are many examples, and this is very important, particularly when we have to administer them during or in the patient who are having bronchial asthma. Now, some of the drugs are able to change the radiographic patterns of lung. So we call it as a what changes they causes during drug-induced lung disease. So there are changes in the alveolar opacities. So when there are focal means there are points in the alveolars, and that causes more opaque in nature. So that means whiteness is appear. If nowadays if you search it, you will find corona related what are the chest radiographs, you will find it how it is. So these which are changing the opacities, these are amiodarone, nitrofurantine, aminosalicylic acid, penicillin, sulfonamide, mineral oils aspiration. The mineral oil aspiration means if it is this mineral oil is going into respiratory tract instead of digestive tract, so we will call it as a mineral oil aspiration. And diffuse alveolar opacities, that is pulmonary edema, cocaine, cytosine, arabinocytes, heroin, then interleukin 2, morphine, OKT3, this ritodrine, salicylate, terbutaline, tricyclics, they will cause alveolar opacities. Then interstitial opacities like methotrexate, nitrofurantine, procarbazine, carbamazepine, these are all will cause affect the structure, anatomical structure. And the drug which can cause pulmonary nodules like amiodarone, bleomycin, cyclosporin, mineral oil aspiration. So these are various drugs. This is what this CAT scan, computed tomography means CAT scan structure normally we call. It is a X-ray along with computerized image processing. So in that we can see that this CT scan will show the signs in the lungs at certain places. So the arrows are mentioning. So this is one example how this amiodarone can cause the enhancement into it, or how the contrast will be changing with the amiodarone. So what can be the treatment? First thing is do not give this drug. You take the history properly, and if you take the history properly, then you will find that yes, these drugs are causing. Example, we know as per our knowledge, aspirin we know, then beta blockers we know, then we have seen ACE enzymes, that is angiotensin converting enzyme. Because why angiotensin converting enzyme can cause cough? Anybody? What is the mechanism? Why ACE inhibitors are known to produce cough? This was also studied. This is part of cardiovascular system. We have studied it. What is ACE inhibitor? Why ACE, or what is the biggest problem of ACE inhibitors? Anyway, you go through this. If you do not remember, then it's good that you go through it. You should try to remember the things. So these are various reasons, various things because of what there are problems associated with the pulmonary function. It affects the respiratory system, and because of that, one by other, there are so many drugs which are causing various problems. So because of all these reasons, The problems are there. We have seen all the mechanism. Today I will not tell until and unless you tell me about what are the mechanism between AC inhibitor causing cough and what is the mechanism behind the anti-inflammatory agents, particularly aspirins. They are responsible, why they are causing bronchospasm, etc. So please go through it. If you have any difficulty, you can ask. Yes, because of the bradykinin inhibition of bradykinin. So what is the problem with bradykinin degradation? Good, Aniruddha, very good. This bradykinin substance P like substances, they will be accumulated. Because of their accumulation, yes, because of their accumulation they will cause cough, and already person who are prone to have cough, example like asthma or any other kind of pulmonary disease, then there will be problem. So this is how these drugs are there. These drugs are causing one by other. If we understand the mechanism, then we can prevent it. We can say that this drug should not be given, and however if they are given, then we can understand about their remedies also, what remedy we can take, about what changes we can make. So this is how various drugs are acting, and on that basis how we can use various drugs. So I'll share you these details sometime, and go through this. If you have any difficulty, you can ask me how these drug are working, and thus we finish the next topic, that is thus we finish the topic, that is drug induced pulmonary diseases. You go through this, and if you have any difficulties, you can definitely ask. Within 1 or 2 days, I'll try to plan the examination, how we can go for, and I'll let you know what we can do for this. Okay? If it is there, you will have to attend it whenever I'll give that signal. Maybe most probably today I am planning. Otherwise, I'll check when I can give it to you. Okay? Take care, inform it to students.